Good afternoon, Commissioners. We're now live.
Good afternoon and welcome to all commissioners and to those who are joining us on the YouTube live stream. And welcome to the HPC's first board meeting of 2023. I'm delighted to welcome Dr. Maddie Castile, who is joining us for the first time as our primary care physician member today, as well as the new appointees from the Healy-Driscoll administration. Both our acting HHS Secretary, Mary Beckman, and also our ANF Secretary, Matt Gorkowitz, will be joining us. Welcome, and in a few moments, I'll ask each of you to spend a moment introducing yourselves. Also wanted to just review the important topics that we have to cover today. We're going to handle some start of the year operational business. We need to elect a new vice chair and determine the assignments for our committee seats for our new board members. The continuing board members will retain their committee seats. Then our executive director, David Seltz, is going to present our agency priorities and agenda for the first half of 2023 for discussion by the board. The Office of Patient Protection is going to provide an overview of the regulatory changes that need to be made this year due to a new law for the board's review. The HPC's market oversight team is going to review material change notices that have been received since the last board meeting, as well as discuss the performance improvement plan review process for the 2022 cycle. And then we will also hear a presentation of the findings and recommendations in a new report that we were asked to do by the legislature on the utilization of telehealth in the Commonwealth. And finally, we have a video that we will show to recognize the HPC's 10-year anniversary. So that's our agenda. And if I could ask each of our new commissioners to introduce themselves. Commissioner Castile, could I start with you?
Absolutely. Thank you, Deb. I'm Maddie Castile. I'm the Commissioner of Health and Human Services for the City of Worcester. I've been the commissioner now for 7 years. A lot of my interest has been looking at inequities in healthcare and certainly dealing with mental health, addiction, and of course we can't forget the COVID years. I am a primary care physician. I've also, as a primary care physician, looked at the inequities that exist in addiction in the Latino community and opened a treatment facility for Latino men called the Hector Reyes House, 2 transition house, and a job training program, which is a cafe called Cafe Reyes. Thank you.
Thank you. We're delighted you have agreed to serve and look forward to working with you.
Thank you.
And Secretary Beckman, could I ask you to introduce yourself?
Sure, thank you. I'm Mary Beckman. I'm the Acting Secretary for Health and Human Services for the Healy-Driscoll administration. I come from the Attorney General's office, where I oversaw the Bureau of Healthcare and Fair Competition for the last 8 years. Prior to that, oversaw the Public Charities Division for several years. And before that, spent a number of years in compliance role at Boston Children's Hospital, in health policy role 20 years ago at EOHHS, here at the state level, and in private practice at Rooks and Gray before that. So, and my very first job was doing discharge planning at Mass General Hospital in the 1980s. So I have some familiarity with some of the issues that some of the constituencies of this commission are facing right now. And my heart goes out to you, and I know that you're doing everything you can in a difficult situation. So I'll leave it at that. Thanks.
Thank you.
I should say, Kate Cook, Kate Walsh was announced this morning as the next secretary. She will be starting on March 1st, and we are really looking forward to that. And we will more to come on that for this commission too. Thank you.
Thanks so much, Mary. Yes, that's a terrific appointment. Very excited about it. Secretary Gorkowitz, could I ask you to introduce yourself?
Sure. Matthew Gorkowitz, Secretary for Administration and Finance. been in public finance and state budgeting for almost 26 years. Most recently spent 10 years at the University of Massachusetts system, overseeing the 5-campus system. And prior to that, I had done my first tour of duty at A&F as both the Assistant Secretary for Budget and Undersecretary for Administration and Finance under the Patrick administration. And prior to that, I've served in various quasis and legislative roles focused on public finance and budgeting. So happy to be able to be here today. Unfortunately, given my schedule, I am only able to stay for the first hour, but I have Patrick Lynch on my team who will be staying for the full meeting, and appreciate being here and look forward to working with all of you. So thank you.
Perfect. Thank you so much. We'll now turn to our first order of business, which is to review and approve the minutes from our last board meeting, which was on December 14th. Can I ask you, Colleen, to take us through the review and approval process?
Absolutely, Madam Chair. Just a reminder to our current and new board members, all votes taken during remote meetings must be taken by roll call vote to be recorded in the minutes. So we will be doing 6 roll call votes today. Okay, do I have a motion to vote on the minutes?
So moved.
And a second?
Second.
Thank you very much. And by roll call vote, Chair DeVoe,
Approved.
Vice Chair Cohen,
Approved.
Commissioner Berwick,
Approved.
Commissioner Blakeney,
Approve.
Commissioner Castillo,
Approved.
Commissioner Cutler,
Approved.
Commissioner Foley,
Approved.
Commissioner Haupt, approved, Commissioner Master Giovanni,
Approved.
Acting Secretary Beckman.
Abstain, as I was not here for the last meeting.
Thank you. And Secretary Gorkowitz.
Same. I have no problem with the minutes, but since I wasn't here, I will abstain.
Thank you.
Thanks so much. Our next agenda item is to appoint a vice chair, and then we'll turn to the committee assignments. Can I ask whether there are any nominations for vice chair? Barbara?
Thank you, Madam Chair. It's my pleasure to nominate Marty Cohen to continue in the role as Vice Chair.
Thank you. Any other nominations or any other commissioners that are interested in serving? Okay, I would say we're ready to, any other discussion? We're ready to move to a vote to appoint Marty Cohen to continue as our vice chair.
Excellent. Okay. Do I have a motion?
So moved.
And a second?
Second.
Excellent. Okay. Chair DeVoe.
Enthusiastically approved.
Vice Chair Cohen, I am not sure if you're supposed to vote or not.
I'll enthusiastically abstain.
Thank you. Commissioner Berwick.
I'd vote yes with thanks to Commissioner Cohen.
Okay. Commissioner Blakeney.
Absolutely, yes.
Commissioner Castillo.
Yes, thank you.
Commissioner Cutler.
Strong yes.
Commissioner Foley.
Yes.
Commissioner Haupt.
Yes. Thank you, Marty.
Commissioner Master Giovanni.
Yes, and thanks, Marty.
Acting Secretary Beckman.
Yes, with gratitude.
And Secretary Gorkowitz.
Yes.
Thank you.
Thank you. Thank you so much. And thank you, Commissioner Cohen, for agreeing to continue to serve in this role. Our next item is that we want to assign our new commissioners to their committee assignments. And as I mentioned previously, our current commissioners will maintain their assignments. And do we have a slide on this one, Colleen, to show?
Yes, we do.
Sorry, yeah.
Absolutely.
Great. So as you see, the proposed committee assignments are shown here. Is there any discussion of these assignments before we turn to the vote? Okay, Colleen.
Okay. Do I have a motion on the committee assignments?
So
I'll
moved.
move.
And a second?
Second.
Excellent. Okay. Chair DeVoe, how do you vote?
Approved.
Vice Chair Cohen.
Approved.
Commissioner Berwick.
Approved.
Commissioner Blakeney,
Approve.
Commissioner Castiel,
Approved.
Commissioner Cutler,
Approved.
Commissioner Foley,
Aye.
Commissioner Haupt,
Approved.
Commissioner Master Giovanni,
Approved.
Acting Secretary Beckman,
Approved.
and Secretary Gorkowitz.
Yes, approved.
Thank you.
Great. Thank you all so much. Our next item is the Executive Director's Report. So I'll turn it over to our Executive Director, David Seltz.
Thank you, Chair DeVoe. Good afternoon, commissioners and members of the public watching on our YouTube channel. Happy New Year. We are so excited to kick off 2023 with a very ambitious agenda for today's meeting and for the next 6 months, which is going to be something I want to focus our discussion on for the first part of my Executive Director's Report. Before I get to that, though, I do want to also welcome our new commissioners and secretaries and acting secretaries. We are so excited to make this connection with you and to work with you and for your input and expertise to contribute to the HPC's work and mission. We are really, really excited. And I will say we are also really excited to work with Secretary Walsh when she begins in her position in March. I do also just want to recognize some of the commissioners who have been serving on this board and thank them for their contributions. Dr. Chris Kreider, who served on the HPC board for 5 years, as well as Secretary Mary Lou Sutters. We do have a special thank you later in this agenda for Secretary Sutters and her service to the HPC. With that, I will want to turn to our first agenda item under the Executive Director's Report. So for this agenda item, we wanted to present to you, the board, for your discussion and input, an ambitious action plan for the first part of the HPC, for the first part of the year. We built this plan off of discussions that have been occurring at the cost trends hearings and in recent board meetings, as well as building off of the priority recommendations that were in last year's cost trends reports. We have a lot of work on our plate and a lot of reports and research that we have been working on for a number of months, and in some cases over a year, that we are preparing for final release. And so to organize our agenda, we wanted to try to kind of bucket all of our activities into some top policy priorities. We think that executing on this agenda will really drive the HPC's mission this year. And also this agenda will provide an opportunity for evolution and something that I hope to bring back to the board at future board meetings for further discussion and refinement for addition as we go through the year and begin to check off some of these important activities. This is really a working document, so the goal for today's discussion is to get your input and feedback as we develop this agenda. So the main topical areas that we've organized the work for the first part of the year, and I'm calling that kind of January through July, are displayed on this slide. I will give a couple of caveats right away, which is to say this is not an exhaustive list of everything that we are working on or that we do. This is really trying to focus on newer areas of work for the Health Policy Commission. So our standard responsibilities in market oversight and care delivery transformation and patient protection will continue throughout the year. Here, really trying to focus on some of those newer priority areas. And so this is not an exhaustive document. And so what I plan to do is I'm going to walk through each of these 6 topical areas and provide a little bit more detail about some of the activities that we're proposing for this year. I'll try to do that relatively quickly, but I do think it's helpful to kind of see the totality of the agenda and how they fit together. And then we'll return to this slide and open it up for conversation and discussion. But if you have questions, specific questions along the way, of course, feel free to stop me. So the first topical area that we wanted to prioritize is bolstering our cost containment activities. Cost containment is, of course, core to the Health Policy Commission's mission and continues to be a priority in this year, as we know that residents of the Commonwealth continue to have high affordability challenges for needed care. There was a report that I think was just released today from our sister agency on the Center for Health Information and Analysis, showing that more of our residents are deferring needed care due to the cost of care. So having affordability and cost containment be a priority policy for the HPC feels right. So the first activity here really is working with the Healy-Driscoll administration and our friends in the legislature to expand the levers for cost containment and to evolve our cost containment approach. And here we're specifically highlighting the 3 priority areas that we included within our cost trends report last year: strengthening the performance improvement plan process, action to constrain pricing, and action to hold health insurance plans accountable and ensure that affordability is advanced through these activities. While we are working with our partners to advance these legislative proposals, we also think there are things that we can do on our own to continue to enhance and evolve our cost containment responsibilities. And so those are really B through E here. First is a recognition that we are going to need to evolve our approach to thinking about the healthcare benchmark accountability this year to account for COVID-19 disruptions in utilization and in spending. The CHIA report that will document our performance against the benchmark is due out in March, and this will be a report that will look at the spending changes from 2020 to 2021. Given what we know about the decrease in spending that occurred in 2020 due to the pandemic, we fully anticipate that report is going to show a very high percentage increase in healthcare spending, could be as high as double digits. And so this will really require us to think about how are we going to think about holding payers and providers accountable in a time period that has so much underlying disruption in the data. Under C here, we do plan to continue to go through our review and scrutiny of payer and provider spending. We also see an opportunity to engage with the new director at the Center for Health Information and Analysis to see if there are opportunities to enhance our data reporting that would better allow us to have insights into spending changes and also the financial performance of our hospitals, providers, and health plans. And finally, under here, do plan to continue to conduct a robust evaluation of the Mass General Performance Improvement Plan. Under D, of course, we're going to continue our role in scrutinizing provider market changes, but see an opportunity to expand that work to include retrospective reviews or reviews of transactions that have already been closed, either reviews where we did do a cost and market impact review and found the potential for some impacts, or for transactions for which we did not conduct a review and an ability to look back and see were there unexpected impacts. I would note in specifically here that we are approaching the 5-year anniversary of the merger of Beth Israel and Lahey Health. And as part of the approval for that consolidation, there was envisioned that the Health Policy Commission would conduct a 5-year kind of retrospective cost and market impact review. So the 5 years is next year, 2024. But I expect that this will be a huge part of our work plan this year to begin to think about how we're going to conduct that retrospective review, especially given the disruptions from COVID. And then finally, an opportunity to continue to collaborate with other state agencies on data reporting and how states can optimize healthcare cost growth targets, working with those other benchmark states. On the next slide, the second policy priority area is addressing healthcare workforce challenges and identifying solutions. I'm going to speak a little bit more about this report that we are preparing in just a few minutes in the next part of my agenda. But we have been working on a report that we think will be able to be released in March. And with the release of that report, we're excited to announce that we plan to convene stakeholders to discuss the findings of the report and also to more broadly discuss the current crisis in our healthcare workforce and to convene and discuss potential solutions. Finally, on the workforce area, we continue to support the inclusion of non-traditional or non-clinical healthcare workers through many of our grant programs and investment programs, and continue to think that there are opportunities to promote different ways of using healthcare workers to optimize both the efficient delivery of care, but also health outcomes. The third priority is around advancing health equity, one of our core goals and missions of the HPC, and part of one of our strongest recommendations in the cost trends report. Here too, we have a report that I'll talk a little bit more about in a minute that examines the relationship between supply, access, affordability on health disparities. We also see this year an opportunity to strengthen the health equity certification standards that are part of our ACO program, to work with a quality measurement alignment task force on the adoption and implementation of data standards for collection of race, ethnicity, language, and other demographic factors. Here too, we see an opportunity to think about new HPC grant opportunities, building off of our current work to reduce disparities. And finally, while there's just a tremendous amount of energy and momentum on common solutions to advance health equity, we want to be aligned with both our partners in the Healey-Driscoll administration, across state government, and with private stakeholders such as the Health Equity Compact, and an internal evaluation of the staff needs to support and advance the health equity work within the HPC. The fourth policy priority area on the next slide is around enhancing pharmaceutical pricing. We have recognized that pharmaceutical spending growth has been growing faster than many other areas of healthcare over the last few years, and continues to present affordability challenges for residents. We continue to want to collaborate with MassHealth on their successful supplemental rebate process in which we have a potential role. But we also think we can go beyond that and bolster our research agenda on pharmaceutical pricing and transparency issues. And listed here are a number of topics by which we are already working on research to present to this board and to release publicly. This first one, prescription drug prices in Massachusetts as compared to international pricing, is planned to be a topic of presentation at an upcoming committee meeting. And then finally, the last big area of policy priority is reducing unnecessary administrative complexity. We heard this again and again at the cost trends hearing, that there is an opportunity for the Health Policy Commission with partners to identify areas where we could reduce unnecessary administrative spending, which we know is so important at a time of real stress in our healthcare provider systems, our healthcare provider workforce. This leads to burnout. It leads to more spending and operational costs. There are so many opportunities for us to do better. And so we are already partnering with Network for Excellence in Health Innovation, which is NEHI, on a program to promote prior authorization automation. You're going to be hearing more about that too at an upcoming February committee meeting. But we think we can even go beyond that and identify other priority areas for streamlining and simplification, and work with a number of other commissions and task force with similar goals. And then truly finally, while not its own kind of policy priority area, we did want to highlight on the next slide a lot of the upcoming topics of actionable research, some of which you will hear more about today or have already heard about. So we'll be issuing a report on telehealth use today, hopefully. And we are preparing that paper on the pediatric healthcare market, which we presented in December. And then finally, as C through G here, a number of other topics that are of importance to the Health Policy Commission and to health policy discussions in our health policy market. So thank you for letting me kind of run through all of that. And I am so excited now to stop talking and to answer questions. But maybe if I could just ask, thank you, return to this slide so we can use this as a guide to the topics you want to talk about.
Terrific. Thank you so much. Commissioner Foley?
Yeah, I just had a quick question on that last slide about the upcoming research on private equity in healthcare. Is it also going to include not just acute care hospitals, but also in a nursing home, in the home care space? Seems like that would be an important piece of the healthcare industry to include in that study. So I just want to make sure that's part of what will be covered in that report.
Yeah, thank you, Commissioner. We completely agree, and absolutely that will be a part of it. We are working to obtain some data and information that has been that kind of documents all of the private equity transactions within Massachusetts. And so we're going to be doing a deep dive into that information and seeing kind of what are the most important trends. But you're right to call out those sectors. Thank you.
Great, thanks.
Commissioner Berwick?
Thank you, Chair. Well done, David. This is a really exciting list. I have two quick questions, both on the bolstering HPC cost containment activities. Just to call out that in the legislative authorization, or maybe it would be more activities on our part, we were focused earlier a lot on variation in prices, and that kind of tailed off in the past couple of years. Is that in your intent to refocus on variation, and in particular, to give us the authority to kind of work hard on the highest cost providers and plans? I think being explicit about that, does that take new legislative authority, David, or can we do that on our own? And I have one other question after that.
So I think big picture response is that topic kind of weaves through a lot of the work that we do. I would, and we can be more explicit in this document. I think if we can move to that slide really quickly, the bolster, slide 13. I think it comes into play in a number of areas. So, one, in our recommendation around strengthening the performance improvement plan process, we do think that there is, the potential for legislative changes that could allow for the upfront evaluation of kind of the differential position of providers in particular when thinking about, who is referred to the HPC on the CHIA list. That would likely require some legislative action. However, as you know, in terms of our internal processes about how we evaluate providers on the CHIA list and the referred entities and consider performance improvement plans, I think my thinking is under B and C here, that there is an opportunity to incorporate into our work, a recognition of the underlying variation and to focus our energy and attention on the entities that are most impactful in terms of healthcare spending. So I do think it is kind of embedded in here, and I can work to kind of make it more explicit.
Thanks, David. Madam Chair, can I ask one more question?
Of course.
This is on item D. David, you and I have talked several times, and you've been wonderful about this. It is time to do a retrospective look at two things, in my opinion. One is when providers or plans have agreed to something, did they follow through, as in the merger report on BID and BI Leahy? And the second is when we declined to do a cost and impact market review, were we right? In fact, when we said it's not likely to have impact, has that been borne out? So, your enthusiasm doing that is terrific. With respect to the first of those, since that activity tends to involve MOUs with the Attorney General's office, are we partnering with them in that review, or will there be two independent reviews, do you believe?
For the Beth Israel review, I would say we are very, very early in this. And so I would absolutely absolutely, we're going to be talking to our friends in the Attorney General's office, our friends in the Department of Public Health, to kind of think about how we can best contribute and not duplicate or overlap with any of the evaluation work that they're doing. So I would say very early on, but absolutely expect to work with those offices. And I can see Acting Secretary Beckman may want to chime in on this as well.
Thanks a lot.
Thanks, David and Chair DeVoe. I just wanted to mention that the Commissioner Berwick was absolutely right that there has been ongoing monitoring of Beth Israel Lahey's compliance with the obligations that they agreed to as part of the assurance of discontinuance that the Attorney General's office entered into with them at the commencement of the system formation, I'll say. There are reports from the compliance monitor that are available on the Attorney General's website. I don't know the address off the top of my head, but there is some publicly reported information already available, and there are ongoing scheduled reports. So that's just, background and baseline, in addition to what I'm sure will be good collaboration in the process that the HPC engages in as well.
Other questions or input from commissioners? Areas of discussion within what Director Seltz has presented, or other areas that you want to make sure we consider and prioritize? Commissioner Cohen?
Yeah, I think this is a great list. It certainly is a wonderful work plan. And I just want to reiterate the need to focus on behavioral health across these domains, although it's not explicitly stated. I think there's some huge behavioral health implications around workforce, around equity, around cost, and just want to make sure that stays as an area of focus for the work ahead.
Yeah, very important observation. We can call that out a little more clearly also, so it doesn't
just to add one response. Thank you, Commissioner. And I completely agree. I think it, some of these issues are both cost cutting across all of these domains, and some of them can kind of easily become their own little buckets. I mean, I think health equity is one of those that is also embedded in 1, 2, 4, 5, and 6. And I kind of think the same way about behavioral health. I will just, I know I'm going to talk in a minute about the workforce report, but in that workforce report, we really did focus on kind of trends and challenges for 3 sectors in the workforce, and behavioral health is one of them. So that is absolutely part of that. And I think some of our research, some of our certification standards, our health equity work, all very much align with that. So thank you for that comment.
Commissioner Cutler?
Thank you. So I agree that this is a terrifically invigorating plan. These sort of trains need to run on different time schedules because of the urgency about some of them, like absolute urgency about some of them, like the workforce challenges, and others are ongoing. And so we both don't want to not do the ones that are urgent because we can't get around to them, but we also don't want the urgent things to crowd out the ongoing stuff that we want. So it's a delicate balancing act. And I think I at least would find it helpful if we had like a sort of a time schedule to go along with with an activity schedule, so that we can say, okay, where do we want to be this year by different points in time with respect to each of these? And then how can we, and then we can always review that and say, how are we doing relative to that?
Yeah, I think that's a great suggestion. I in preparing these slides, we kind of had a version where we, for each one of them, kind of had a little bit of a date, and it just became a little bit of information overload. And maybe there's a way, Professor Cutler, we could even maybe color code them in some ways. Maybe that's a little, but the intent behind that is absolutely correct. I think this is something that we would hope to, as I said earlier, bring back to the board, in July and say, okay, we've done these things, we've issued these reports. This work is still ongoing. Maybe this work took a little bit longer than we anticipated, and to help us prioritize. I will mention that as part of kind of that thinking about how we prioritize, I'm going to share our proposed agendas for the February committee meetings. And you can see a number of these activities are already slotted into our first set of public meetings. But I like, maybe there's a color coding way. I'll think about it, but thank you.
Great. Commissioner Master Giovanni?
Thank you. And Dave, thanks for putting this together. It's an important list. My question's related to, you mentioned the work that's being done on telehealth, and I know we're going to be discussing that in far more detail today. But what I was wondering is if you've already done or in the process of doing a cost comparison other than the facility charge for the difference in expense for an operation running telemedicine versus a face-to-face type visit, and what those variances and costs are, if any.
Thank you, Commissioner. That is definitely an area that we call out in our telehealth report as an area for ongoing further research to try to understand the underlying operating cost differences from this modality and for different services. It was not something that we had kind of the right data and information to examine in this report, but we do call that out as something that we need to look at in the future. And so we'll add that to the list. Thank you.
Great. Yeah, I think it'll be interesting to look at startup costs separate from the ongoing costs once telehealth is up and running. Good point. Other questions or comments on the priorities? As Director Seltz pointed out, this is really for the first 6 months of the year, understanding that we'll look at the second half of the year as we get deeper into 2023 and come back if there are other priorities to be added or changed. Any other input on this?
Hearing none, I think I can move on. I just one last point on that list of priorities for board members. We very much welcome your help, guidance, input, energy and time if there are, certain of those policy priorities that you would like to be more closely engaged on. And so encourage you to reach out to us so we can make sure to put you on the team, so to speak, as we advance that ambitious agenda. So for the next part of my executive director's report, I did want to spend a little bit more time just previewing 2 upcoming research publications. So the first research publication that I wanted to highlight was the impact of COVID-19 on the healthcare workforce. So as part of COVID recovery legislation, the legislature tasked the Health Policy Commission with studying and reporting on the state of the Commonwealth's healthcare workforce, including such topics as workforce shortages and workforce initiatives. This is obviously a timely and extremely important topic as Massachusetts and really the entire country continues to face unprecedented workforce shortages and high turnover, which have contributed to delays and disruptions in patient care throughout the healthcare system. And I want to highlight a report from the Mass Hospital and Health and Hospital Association that was released at the end of last year that surveyed providers and really highlighted a number of the challenges facing the healthcare workforce, shortages, capacity constraints, and leading to patients being sometimes not being able to be moved out of the emergency department or not being able to be timely discharged from the hospital. As addressing the workforce predicament and challenge is an essential priority for so many organizations and is interrelated with our mission around cost containment, our upcoming report really takes a broad system-wide approach to these trends and challenges. And we did, in addition to that broad system-wide focus, we did also want to have a priority look at 3 sectors. So we prioritized nursing, direct care, and behavioral health care. And our report is framed in terms of what we're calling this workforce life cycle, which is from pipeline through training and employment to retention to advancements. Where are the challenges and where are the opportunities. On the next slide, just to preview a little bit more about the component pieces of this report. So we include both a lot of discussion with stakeholders. It includes our own original quantitative analysis and data analysis of workforce trends. We also contracted with Mathematica to do some case studies on initiatives and programs that address challenges at each stage of that workforce life cycle. And then finally, we also contracted with an expert to do a policy review of nursing and direct care practice regulation and oversight in Massachusetts as compared to 3 comparison states. And we plan to have a set of recommendations. So on the last slide here, just to give you, again, a little bit of a preview, this on the top part of the slide, you can see the different organizations and programs that we consulted with for those kind of case studies, again, spanning the employment life cycle and also spanning across the Commonwealth. So in conjunction with the release of this report, we are excited to announce today that we plan to hold a special event with the release of this report to convene the stakeholders and other interested parties to engage in a robust discussion about the challenges and the solutions that are so top of mind to our healthcare system today. So we have set a date for that. We are still working on a location and an agenda, all of that to come. But prior to this event and in the next month or 2 months, you're going to be hearing a lot more from us about this report. You're going to be able to, provide comment on draft versions of this report. So you commissioners will have a lot of input as we kind of finalize this report and prepare for this agenda. And I look forward to working with you to develop an agenda here that can really help advance this important conversation. So before I move on, any questions about this upcoming preview and this upcoming event? Commissioner Foley?
Thank you, David. Great presentation, and I love how you're structuring the report, and I really look forward to both the report itself and in particular the policy recommendations, because I do think, as I stated in past meetings, to really strengthen some of the recommendations that came out of the cost trends with specific recommendations as it relates to the issue of workforce. So I'm really looking forward to that, and I think it's clearly a very important conversation. And I just think having this event is just a really great idea to bring folks together. I think it's responsive as a commission to what we've been hearing, and we heard at the cost trends hearing that workforce is the #1 issue that I heard across a lot of the providers, and not just in acute care hospitals, but through the continuum of care and nursing homes and home care. So I think this is exactly what we need to be doing, is convening this group, be responsive to what we've been hearing, and try to come forward with some clear recommendations for the incoming administration and legislature about how each of us can work together to address this significant issue that's persisted. And also know that there's no short-term solutions here. This is going to be a long-term approach that we all need to be working on together in coordination and support one another through this really difficult time. And I think this is a great sign of times to come about us convening and having a really important conversation and helping shape the debate and discussion around recommendations to begin to address this crisis in care. So thank you for the responsiveness and for this great opportunity to have that dialogue and continue the conversation.
Thank you, Tim. Commissioner Blakeney? Do you have a question?
Yes, thank you. Some of my comment was spoken quite eloquently by Commissioner Foley, so thank you, Tim, for that. As we think about going forward, and as we think about the special event, David, one of the things that I think we have to think about is that the situation is so dire, both from a financial perspective and from bodies, on the ground, clinicians in place, technicians in place, all of us healthcare workers. It's an across the board issue. that is going to require some significant, I believe, some significant commitment by our state government and by our national government to find the resources to pull people back into the work that they love but can't do anymore. Do not have the energy and the ability to deal with what the environment is and work. And so as we look at this, it's not only looking at the condition of the workforce, it's looking at the condition of the environment. And it's looking at the condition of the participation of our patients in care, what delays people from getting care. At the moment, I happen to know that there's an 8-month wait to schedule colonoscopies in many areas of the state, 8 months. And so it's a broader issue. We don't have the resources, so we don't have the availability. So I think as we approach this, we recognize that the workforce issues are a linchpin in solving the broader issues. So it's a good thing that we're doing this. It's a good thing that we're inviting broad comments. And I look forward to putting together a very robust program. I wonder if 10 to 1 is enough time. Sorry, but I do.
Yeah, good point. Good point. Commissioner Cutler?
So I think my comments build a little bit on the past couple of comments, which I suppose my way of summarizing it is this doesn't feel like a one and done kind of thing. Like sometimes a report, sort of encapsulates it and then that's kind of done. And then, people need to absorb that and so on and so forth. Whereas this feels like more of an ongoing issue that needs to occur. Obviously it's occurring now even before the event, needs to occur afterwards and so on. And so I almost want to think about this event, which I think is incredibly needed and valuable in terms of how is it going to fit into the conversations that are undoubtedly taking place and that need to continue over time. And so how do we both build on what's going on and set the stage for going forward and be part of those conversations, as opposed to kind of, we're going to identify issues, raise them, and then we're going to kind of leave it there.
Yeah. So recognizing the long-term nature of this, as several commissioners have commented, you're really saying, is there a role for us to play in continued convening and facilitation and evaluation?
Yeah.
Good point.
Well, just to say thank you to the comments from all three commissioners on this, and we really look forward to working with you on the finalizing the report, the recommendations, and the event. And I absolutely agree, Professor Cutler. This is we are not in any way suggesting that this event and report is somehow going to solve our workforce challenges. It is really, I think, an opportunity to bring people together and to and perhaps, we can be intentional in thinking about the agenda and, making sure that we save some time for discussion about what comes next and how can the Health Policy Commission continue to play a constructive role. And I also, want to recognize that Governor Healy has made, workforce challenges a big priority of hers. And I think, there'll be an opportunity for us to see how we can partner with that administration and with other agencies that oversee this workforce. But just a note of agreement and thank you and gratitude.
Commissioner Berwick?
Yeah, thanks. It's going to be wonderful. I'm sure you're planning on doing this, but I'd like to endorse it further, that make sure that the use of the time for this event includes the voices of people with this lived experience, especially marginalized people. This is a real chance to let the kind of poetry of the workforce surface through their own testimony.
Yeah, good point. And to include the focus on the patients and what this means for them in terms of access, quality, and some of the issues that you and Commissioner Blakeney were raising. Great. Other comments or questions?
Hearing none, I'll move on to the next report preview. This report is a little bit probably further out in terms of a timeline, probably later spring or early summer. A lot of work still left to do with this report in terms of incorporating all of your input and feedback. This is a big report that we really want the HPC commissioners to have a strong voice in helping us develop it, because it is such a difficult and important topic. So on the next slide, this was again a charge from the legislature that we analyzed the impact of COVID-19 on a number of different kind of factors. And so one part of that legislative charge was looking at the impact of COVID-19 on the healthcare workforce. I just mentioned how we're approaching that. There was also a legislative charge, kind of looking at the impacts on utilization and on spending. We issued a big report on that in April 2021, but we've continued to update those findings and bring them back to the board. There's another part of the legislative mandate here, though, that charges the HPC with looking at an analysis of healthcare disparities and several analyses related to provider supply, including what are the essential components of a robust healthcare system, an inventory of and description of the supply of healthcare services, and an examination of the closure of services and the impact those closures have had on quality and access. So we've carved that charge into a separate publication that we've been working on for over a year at this point, and are hopeful that we'll be able to release it in the first half of this year. So our current approach to this report is displayed on this slide. So we propose to start by describing the problem of health disparities in the Commonwealth. And our primary aim here is to aggregate, organize, and interpret the breadth of data that has been published on this topic recently, including data and findings from the Attorney General's office, CHIA, DPH, private foundations, researchers, and others. Our focus is on reports that are recent and specific to Massachusetts. And our goal is to understand how factors including race, geography, and income are associated with different health and healthcare experiences in Massachusetts. Then we plan to examine the factors that contribute to the problem. And consistent with the statutory charge, we're really focused on systemic factors within the healthcare system, as opposed to broader drivers, such as social determinants of health. So what are the drivers within the healthcare system? And we start by inventorying the number and distribution of several supply types, including clinicians, beds, and other facilities. Then we evaluate our state and at an county level and compare those to some competitor states, the national average, as well as international competitors. And we examine whether certain populations are more likely to live in areas of higher or lower supply in an attempt to understand the role of supply in healthcare disparities. And then finally, we want to acknowledge what researchers and policymakers have known for decades, that supply is not equivalent with access. So we are also considering how other health system features, such as how we pay for healthcare, may be related to the disparities that we observe in the first section of the report. So on the next slide, as I mentioned, we are still hard at work at this. We've been working with our expert teams, and in the next 2 to 3 months plan to do a series of meetings with each commissioner to review our approach, some of our preliminary results as we develop this into a full report to the legislature, hopefully by early summer. So with that, I wanted to highlight that important report, and happy to take any questions at this point, but also a lot more work to come on this. Great. Seeing none, I will move to my final agenda item of the Executive Director's report. Thank you for all of the input. as I mentioned, wanted to kind of highlight that from our action plan that I discussed earlier, we are hitting the ground running in terms of executing on that agenda plan for our first committee meetings. And so at the Market Oversight and Transparency Committee, we have 3 agenda topics that are right from our policy priorities list that I just presented. A research presentation on ambulance utilization and payment rates in Massachusetts, a new research on assessing drug prices in Massachusetts. And then finally, we're excited to be joined by our colleagues and partners at NEHI for a presentation about that partnership that I discussed earlier around promoting automation of prior authorization. On the Care Delivery Transformation Committee meeting, we're thrilled to have a guest from Mass Health who is going to be talking about the evolution of the Mass Health ACO program and potential alignment with our work, as well as our own ACO certification program and opportunities to strengthen our health equity standards in this coming year. As always, commissioners, you are invited to both meetings, whether you are a member of one committee or not. And given, I think, a lot of interest in these topics, I can imagine that you may want to book off the full time. And so look forward to a great set of committee meetings in February. And that is the conclusion of my executive director's report. And I think we can move on to our next agenda item. For this next agenda item, we wanted to present for your vote and consideration regulatory changes that govern the Office of Patient Protection as required by a recently passed law. The vote here is to advance these regulatory changes to a public comment and to public hearing for final approval later this year. And so with that, I'm very happy to turn it over to Nancy Ryan, who is the director of the Office of Patient Protection at the Health Policy Commission.
Good afternoon. As David said, I'll be presenting on the Office of Patient Protection's proposed regulation that we hope to issue today for public comment. As a reminder, for our new commissioners and others, OPP has 4 primary services offered to consumers. We allow consumers to purchase health insurance outside the open enrollment period. We regulate internal grievance processes and administer external reviews for consumers who have been denied coverage by their health insurance company. We regulate and administer appeals for patients of accountable care organizations. And we also operate a hotline and answer online inquiries addressing a wide number of patient concerns. The presentation on the proposed regulation today primarily focuses on that second grouping there related to health insurance appeals. On the next slide, there's a little bit of an overview of Chapter 177 of the Acts of 2022, also known as the ABC Mental Health Act. This slide summarizes how that law amends OPP's duties as they pertain to regulating the internal grievance process, processing external reviews, and monitoring carrier compliance with mental health parity in conjunction, of course, with other state agencies. So that first row, section 64, 65, and 71, amend health plan responsibilities relating to internal grievances, also known as internal appeals processes. It's necessary for OPP to update its regulation for these sections of the law. Also, sections 66 through 69 make several changes to OPP's external review process, and these sections as well necessitate updates to OPP's regulation, and OPP also released interim guidance related to these sections in October. Lastly, sections 22 and 70 codify OPP's role in mental health parity compliance at the state level. The law mandates that OPP monitor denials and trends and refer complaints regarding mental health parity to the Division of Insurance, the Attorney General's Office, and the Group Insurance Commission. This is largely sort of what OPP already does in practice, but the law also mandates that the Division of Insurance consult with OPP when performing mental health parity market conduct examinations on health plans. Regulatory changes are not necessary to implement these sections in the last row as they pertain to state agency requirements rather than market participants. The next slide, you can see some of the implementation and outreach activities by OPP in advance of issuing the proposed regulation today. In terms of outreach, we reached out to health plans and consumer advocates in the fall after the law's passage, and we continued discussions with the Division of Insurance regarding the changes to mental health parity implementation and anticipate continuing those discussions, for many, many months. In October, OPP released interim guidance notifying health plans and other parties about the immediate changes to OPP's external review process in compliance with Chapter 177. 177 went into effect November 8th. The interim guidance is in effect until the issuance of the final regulation. And as required in the interim guidance, OPP collected reporting from all health plans. They were required to submit detailed information to OPP about how they send internal grievance responses in compliance with Chapter 177. And we collected that reporting from every health plan and have that information to use in implementation until the final regulation will be passed. Also in October, before the effective date of the law, we issued guidance to our contracted external review agencies, notifying them of new processes under the law and a new standard for requests of continuation of coverage. The next few slides really go into some of the proposed regulatory changes with specificity. By way of background, the proposed regulatory language closely follows the statutory text. Chapter 177 provided really detailed descriptions of the changes to health plan internal processes and also the changes to the external review process. So the regulation, always closely hews to the statutory text, and in some cases, really mirrors the exact statutory text, as there wasn't any need for further clarification. I'll first detail the changes to health plan internal processes and then move on to the changes to OPP's process. First, on that first row, the regulation requires health plans assess any new or amended medical necessity guideline to show compliance with mental health parity requirements. So this was not a requirement before in the law, but now health plans must do this for any new or amended guidelines that they put into place. On the second and third row, the regulation also requires that health plans establish a clear process allowing the insured to appoint an authorized representative, and health plans must establish a process ensuring that patients can sign medical release forms electronically. On the next slide, there's further changes to internal processes dealing with the internal grievance process in particular. The regulation requires health plans to send internal grievance responses by certified or registered mail with proof of delivery. This is an example of the regulation text mirroring exactly the statutory text. And in this case, you can see just how specific the statute really was with some of these amendments to health plan processes. The regulation also expands health plan obligations to patients whose expedited internal grievances have been denied. Those patients will now have a right to request a conference after that internal appeal denial. This is an expansion. Right to a conference used to be just for patients with a terminal illness, and now it is for all patients who've had an expedited internal appeal denied. Now we're going to move on to the next slide that deals with some of the proposed changes to OPP's external review process. First, in external review cases where there is evidence of a health plan not complying with the internal grievance timelines, the external review will be ruled in favor of the patient. This section relates back to that proof of delivery requirement for mailed responses to the internal grievance process. The proof of delivery will be substantial evidence that the health plan did meet the internal grievance timelines. If that's not present, then it will be ruled in favor of the patient and that the grievance timelines weren't met by statute. Second, the regulation implements the statutory requirement that a complete medical record for external review compiled by the carrier must include medical records and medical opinions by the patient's treating provider. The regulation also requires the external review agency to consider related rights under state law as directed by OPP when deciding cases. This is similar to sort of what OPP does in practice. We have several bulletins available on the HPC's website that gives information and clarification on state laws that are relevant to certain types of cases for external review. This is codifying sort of this practice into law and regulation. The next slide lists the last requirements in the proposed regulation for external review processes. The regulation, as directed by statute, explicitly allows consumers to request continuation of coverage in non-expedited external reviews. It is the external review agency that decides whether the coverage should be continued, and under the proposed regulation, the external review agency must newly consider prior denials that have been overturned at either internal or external review when deciding whether to grant the continuation of coverage. And then finally, under the proposed regulation, a health plan's failure to comply with an external review agency's decision would be a violation of the state consumer protection law 93A. I can pause now if there's any questions that commissioners have about the regulatory changes.
Thank you, Nancy. Commissioner Blakeney.
Thank you. And Nancy, thank you for that report. And listening to you and following along on the slide, it raised a question for me, which is, what is your analysis at this point of the additional work responsibilities for the patient protection department here? What are you anticipating is going to happen as a result of these new regulations?
I think that the changes to the external review process, are changes that we've already implemented to a certain degree with providing guidance to our external review agency around the new continuation of coverage standard. And we've already changed our processes around allowing requests for continuation of coverage in non-expedited appeals. We also will have to change our request form and certain other sort of internal processes to allow for the changes to go through. And another piece that we already do is sort of monitor for behavioral health complaints, monitor for mental health parity complaints, and work closely with other state agencies. So we anticipate a continuation of that and, potentially some sort of formalization of those relationships.
Okay, thank you.
I do want to put in a plug, though. We do have an opening on the OPP team for program assistant. That's on our website, mass.gov/HPC. Please share. Thank you.
Thank you, Colleen. Yes.
Well done, Colleen. Well done.
Yeah. Commissioner Haupt.
Yes, thank you. Nancy, this might be in the weeds, but on the Section 68, expanding the opportunity to request continuation of coverage. What happens in the instance where somebody is on COBRA and going through this process? Would this actually possibly extend the outer limits of COBRA, which is federal regulation? And it may be too much detail at this point in time, but just that's something that occurred to me because so many people are taking advantage of COBRA.
Yeah, so it wouldn't extend anybody's eligibility for COBRA. Basically, if someone has to be on the plan, someone has to be a member of the plan and in order to have any benefits paid by the plan. Sure. So if our process is ongoing and someone is no longer on that plan, then the external review decision, should it be decided after the person is off the plan, we don't have any control over that. That decision then no longer applies to the person's new plan.
Yeah, I'm just worried about somebody going through this long process, being denied, and eventually maybe being approved, but then running out of benefits eligibility. And it's all, something that wasn't treated that maybe was eventually ruled in their favor, and now they no longer have coverage available to them. But I'm not sure you have control over that anyway.
We don't have control over that at all in terms of eligibility, but we do offer an expedited process,
Okay.
which if someone, knew that they're running up against certain timelines and they met the expedited criteria, then that's something they could definitely take advantage of.
Okay, thank you.
And if someone was switching coverage in that, Nancy, would they then have to restart the process to
Yes.
list to their new plan? Okay, good to know. Commissioner Berwick?
Thanks so much, Nancy. This does not apply to ERISA plans, I assume?
This applies to only fully insured Massachusetts-based plans, so it doesn't apply to self-insured plans.
Do we hear complaints from people in self-insured plans, or we don't even know about them?
We do. I mean, through our hotline and our email and online inquiry process, we certainly hear from people who have self-insured plans. We, provide guidance and referrals to those people, and we can, provide information about the internal process for appeals and the external review process, as it's very similar in the self-insured area, but we can't process those appeals. We can't regulate those plans.
Do we keep a record?
We have records of our internal inquiries, and we also have records of external review cases that have been ruled ineligible, some of which are ruled ineligible because they're self-insured.
Thanks, Nancy. And last question, the 93A move sounds pretty big. I mean, that's an important step. Am I correct? And do you want to say any other comments about its importance?
I think it, states explicitly that it does state explicitly that it is a violation of 93A. So I think it, it provides comfort to people that that's explicitly stated in the statute and the regulation. I think that some right to implement that has always been in existence, but this, just states it explicitly.
And I'll just note that we haven't experienced, many, if any, instances of health plans failing to comply with external review decisions so far.
Thanks, Lois.
Thanks so much, Nancy. And just to follow on to some of the questions that have been raised, are there any areas of this that we should be particularly concerned about, either in terms of the challenges in implementation or the work effort on that behalf of the team?
I don't think so. I think that we are, well positioned to implement this. We've done outreach. Many of the changes are, will have an impact on patients and, are patient protective, but are sort of slight tweaks to an existing process. So I think, we're in a good place to implement that. And we do really look forward to receiving public comment on the regulations.
Thank you.
I have a timeline on the next slide, which might sort of clarify where we go from here. So if the board votes to issue the proposed regulation today, we plan to have a public hearing on March 2nd at 2 p.m. The public hearing notice will be posted on our website and will have information about how to participate in the hearing. All are welcome to testify at the hearing, and written comments will be due 1 week after the hearing on March 9th, after which HPC staff will review the public comment and make any sort of necessary changes to the proposed regulation. And we hope to bring a final version to the board on April 12th.
Great, Nancy, thank you. Any other questions or comment from board members before we move to a vote on whether to release the proposed regulation? Okay, Colleen, can I turn it over to you to take us through the vote?
Absolutely. Let's get that vote slide up. Do I have a motion on the table?
So moved.
And a second.
Second.
Okay, Chair DeVoe, how do you vote?
Approved.
Vice Chair Cohen?
Aye.
Commissioner Berwick,
Aye.
Commissioner Blakeney,
Aye.
Commissioner Castillo,
Yes.
Commissioner Cutler,
Yes.
Commissioner Foley,
Aye.
Commissioner Haupt,
Aye.
Commissioner Master Giovanni,
Approved.
Acting Secretary Beckman,
Yes.
and Commissioner Lynch. Welcome. How do you vote?
I'm a yay. Thank you very much.
Thank you so much.
Great. Thank you all. Thanks so much, Nancy. Any other comments before we close on this?
No, thank you very much.
Okay.
Great. I'll take back over the agenda here. Thank you so much, Director Ryan. And we're going to move into the market oversight portion of today's agenda. 3 agenda items here. One, our standard update on material change notices. We want to provide a public report out on our performance improvement plan review process for the 2022 cycle. And then we're going to be spending a fair bit of time presenting and discussing a new report on telehealth use in the Commonwealth and associated policy recommendations. I'll actually do the first agenda item here because it is relatively short. For new commissioners, this is a standard agenda item that we have for board meetings where we will update a list of all of the material change notices that we've received since the HPC's inception. We'll review any new notices that we've received since the last board meeting, as well as notices that are still under review and notices that either were elected not to move forward to a cost and market impact review or that were elected to move forward to a cost and market impact review. So today's report out will be relatively short. Here is just our updated list of the 148 market changes and their type of transaction over the last 10 years, with formation of contracting entities and clinical affiliations and physician group acquisitions continuing to lead the pack. We only have 2 transactions currently under review. And so these are still under review. The first is a proposed purchase of LHC Group, which is a national provider of post-acute services, including several home health locations in Massachusetts by United Healthcare. Under the proposed transaction, LHC Group would become part of Optum Health, a subsidiary of United. And I would note that this transaction is still under review by the FTC as well. And the second is a proposed clinical affiliation between Tufts Medical Center and Commonwealth Radiology Associates, which is a large radiology physician group practicing in multiple locations. Under the proposed affiliation, CRA would become the exclusive provider of professional radiology services at Tufts Medical Center. So we are still under review of these transactions, but happy to take any questions or comments if commissioners have those at this time. Great. Seeing none, we'll move on to the next agenda item under this topical area, which is our report out on the very long, intensive process by which the Health Policy Commission each year receives a confidential list of entities for review and for potential consideration of a performance improvement plan. And so I'm going to turn it over to Kara Vidal, who's going to walk through this process very quickly, what years were under review, and the final decisions of the board at the last board meeting in executive session. Take it away, Kara.
Great. Thank you so much, David, and good afternoon, commissioners. As David said, I'm here today to just provide a brief public recap of the 2022 PIPS review cycle, which concluded last month. So by way of brief background, each year CHIA identifies and refers to the HPC payers and providers whose spending growth is excessive and who threaten the ability of the Commonwealth to meet the healthcare cost growth benchmark. CHIA evaluates growth against the benchmark at an individual contract or book of business level. So for example, a provider could be referred for above benchmark growth in a single contract or for multiple contracts. And CHIA is required by statute to base its referral on health status adjusted spending growth, which we heard quite a bit last month from David Auerbach on risk scores and health status adjustment. So we know that while the use of health status adjusted spending is meant to account for differences in patient health status that might explain higher or lower spending levels between organizations, it also reflects provider coding practices. And we'll discuss that later in this presentation. The factors that go into CHIA's referral are largely dictated by the PIP statute, and CHIA makes referrals based on a standard algorithm that is applied identically to all payer books of business and provider contracts. So our job then is to take that list of entities and provide a more comprehensive analysis to contextualize each entity's spending growth. We analyze the spending performance of each referred entity, and we examine measures beyond HSA growth, health status adjusted growth. So for example, we look at baseline spending levels, we look at pricing levels, size and market position, population served, and other relevant factors. If the HPC identifies questions or concerns about an entity's performance, it can require the entity to meet with HPC staff and provide additional data and documents. If after that back and forth, there is still concern about an entity's spending performance, the HPC can require a performance improvement plan. Because the identities of referred entities are confidential by statute, the board primarily meets in executive session to discuss each referred entity's performance. So our goal for today is to summarize that 2022 process publicly. You can go to the next slide. Thank you so much. So in a typical year, CHIA refers entities based on 1 year of trend. However, due to changes in its data collection process, the 2022 cycle included referrals from CHIA based on 2 years of data. So it's 2018 to 2019 and 2019 to 2020 that were under review. And entities could be referred for their performance in a single year or both years. Prior to updating its reporting timeline, CHIA used to publish preliminary TME data alongside the final data on which it bases its referrals. So we have previously reviewed 18 to 19 preliminary trends for referred entities. We reviewed that as part of the 2021 process. When we looked this past year at the final 18 to 19 trends, we found that they were largely consistent with that preliminary data that we'd already taken into account in the 2021 process. The 2019 to 2020 data were fully new. However, as we all know, 2020 was a very unusual year in terms of trends. So if you look at the chart on the bottom of this slide, we often, or always to this point, have seen year-over-year growth in spending. In 2020, we saw declines in spending driven by reduced utilization of in-person services during the pandemic. So on the next slide, one important feature of the PIPS review process to note is that although actual spending declined in 2020, health status adjusted spending, which again is the basis for referral by CHIA into the PIPS process, increased for many payers and providers. And that is because average risk scores, which as you can see were consistently growing, dropped in 2020. So in other words, 2020 saw a decline in patient risk, or said another way, an improvement in patient health. However, as David Auerbach so helpfully explained last month, the Massachusetts population did not actually become meaningfully healthier in the middle of a pandemic. What we're seeing here is related to the decrease in healthcare utilization that occurred. So because patients had fewer encounters with the health system, providers had fewer opportunities to record diagnoses, which led to risk scores showing improvements in health. And the next slide shows how this dynamic impacted individual payer and provider referrals. So if we start on the left-hand side, you will see a graph that shows the difference between unadjusted spending growth and health status adjusted spending growth for a representative set of provider contracts. These data are from 18 to 19, 2018 to 2019 trend, but they're consistent with what we have typically seen year over year. The blue hashed line in the middle is the benchmark. And so if you look at the far left-hand side of the slide, you'll see that for this set of representative contracts, again, not everything that we looked at in the PIPS process, but a representative set, you'll see that many had real dollar unadjusted spending growth that was above the benchmark. However, once the risk scores are factored in, the health status adjusted levels were below the benchmark. And that is because, as we said before, prior to 2020, risk scores were growing year over year. This means that those contracts could not be referred into the PIPS process, and therefore those entities couldn't be evaluated for a potential PIP. If we look on the right-hand side of the slide, we see the opposite pattern. So note that the slope of the line has changed. Because risk scores were dropping in 2020, health status adjusted growth for many entities was positive, even though real dollar spending was declining. So that means that many entities were referred to the HPC for their 2020 trends, despite the fact that they actually spent less in 2019, but less in 2020 than they did in 2019, and despite the fact that there's no reason to think their patients were truly getting healthier. So the HPC has raised concerns about requiring referrals be based on health status adjusted growth in the past, and we think that this year's PIPS process really underscores the concerns that provider coding practices and the resulting risk scores can skew referrals into the PIPS process. On the next slide, you'll see the conclusion here. So before I jump to that, I'll just say that despite these unusual circumstances in the world, and therefore in the data that we use in our process, we did conduct the same comprehensive, rigorous review of each referred entity that we conduct every year. We shared those results with the board last year, and in December, the HPC elected not to require a PIP from any entity based on 2022 referrals. This decision really reflects the fact that we had previously reviewed and acted on preliminary 18 to 19 trends. The 19 to 20 trends were disrupted by the pandemic, as well as a recognition of the ongoing challenges facing the healthcare system and a desire to avoid placing additional administrative burdens on entities at this time. My last slide, like Nancy's, is also a timeline slide. So the 2022 cycle is complete, but 2023 is right around the corner. We expect SHIA will refer entities based on their 2020 to 2021 trends later this spring. And as David Seltz mentioned earlier today, we are working closely with our actuarial experts to develop techniques that will allow us to perform a meaningful analysis of their performance in 2021, despite the fact that 2020 spending levels were depressed and 2021 is likely to show very high increases. So we expect that analysis, as well as any potential follow-up with entities of concern, would take place this spring and summer, and that the board would be in a position to consider whether a PIP is required around the end of this year. And that is all I have.
Thank you. Any questions from commissioners? Okay, well, thanks so much.
Thank you.
Thank you. Excited to move on to the final big agenda item for today's meeting, which is a presentation on a report on telehealth use in the Commonwealth. Many of the results that we'll be presenting today were shared at a committee meeting at the end of last year, but because this is such an important report, because many commissioners were unable to attend that committee meeting, we did want to come back to present some of the key findings before turning our conversation to the policy recommendations. This was another report that was required of us by the legislature, I think in recognition of how important telehealth use became in the Commonwealth during the pandemic, and really leaning on the HPC's expertise to provide recommendations on a number of different policies. So very excited to turn over this presentation to our lead researcher on this report, Yua. And again, she will present a number of the slides before we, quantitative slides before we get to the recommendations, and encourage commissioners to stop and ask questions along the way. But I'll turn it over to you, Yua.
Great. Good afternoon, commissioners. I'm really excited to talk about the telehealth report, which we're expected to release today. I'll highlight some of the report's findings first, and then we'll go over the recommendations at the end. But first, a quick refresher on the policy context for this report. At the beginning of the pandemic, Massachusetts, like many states, mandated the coverage and reimbursement for telehealth services to facilitate access to care. And in January 2021, the legislature passed Chapter 260 of the Acts of 2020, which mandated permanent payment parity between telehealth and in-person services for behavioral health, for primary care and chronic disease management. The legislation mandated temporary parity, which expired on January 1st, 2023. And as part of Chapter 260, on the next slide, as part of Chapter 260, the HPC was tasked to conduct this study on telehealth, analyzing utilization and spending trends, and we were also asked to provide policy recommendations on a number of topics, including reimbursement levels and ways to expand appropriate use of telehealth in the Commonwealth. So we mainly, on the next slide, we'll start with the results. We use the Massachusetts All-Payer Claims database to look at utilization, and you can see that in 2020, telehealth ramped up quickly at the beginning of the pandemic and peaked in April, accounting for 66% of all ambulatory visits. And over the course of 2020, telehealth use gradually reduced and remained at about 30% or so towards the end of the year. Taken all together over the course of 2020, on the next slide, we can see that about a third of all ambulatory visits were conducted over telehealth, with more than 50% of all commercial members taking advantage of this modality of care for at least one visit. This is compared to 2018 and 2019, where less than 1% of commercial members had some kind of telehealth use. Next, we looked at telehealth use by clinical areas, and we found that there was significant variation. For mental health conditions, telehealth was the predominant mode of delivery. You can see here, this is the first bar, 66% of all mental health visits were conducted by telehealth in the year 2020. On the next slide, we combined all the visits that are unrelated to mental health into one line. You can see the contrast here. For mental health conditions, telehealth use was high and remained high through the entire year of 2020 at about 80%. For non-mental health conditions, telehealth use peaked in April and then dropped over time once patients had the option to return in person, and stayed at about 15% or so towards the end of the year. On the next slide, we have one slide here that shows telehealth use for a select Mass Health ACO and MCO population, and we found that the monthly pattern of telehealth use was pretty similar between this population and the commercial population, which was the focus of our report. Okay, next we will move on to areas of telehealth use where there are variations. So first, we looked at geographic variation. This map shows among patients who had visits for non-mental health conditions, what % of them had any telehealth use by zip code? And you can see that telehealth use for, again, non-mental health services was higher for residents in Metro Boston and the Pioneer Valley, Franklin region, and lowest in the central Massachusetts. On the next slide, again, here we looked at telehealth use for non-mental health services, but we looked at variation by patients' attributed provider organization, and you can see here there's quite a bit of variation by provider organization here. On the next slide, again, looking at variation by provider organization, but here we're focusing on patients who had at least a visit for mental health conditions. We do still see some variation, but the variation here is smaller as telehealth use it's higher for mental health conditions across the board. Because we know that Many of the factors that I just discussed, clinical conditions, provider organization, geography, all these factors are interrelated. We wanted to see how much each factor contributes to a patient's likelihood to use telehealth. So we put everything into a regression model, and the results are on the next slide. Here you can see that we factored in mental health history, patient's age, their sex, risk score, community income, and geography, and community internet access. And we found that telehealth use was higher for patients with higher risk scores. And we found that telehealth use was also higher in urban areas compared to rural areas. And we also found that internet access in the community, it's associated with more telehealth use. We found that there were pretty minimal differences by community income levels. You'll notice here that we were not able to look at telehealth use by race and ethnicity in this regression due to data limitations in the APCD. So we set out to understand the impact variation in telehealth use by race and ethnicity based on other literature, which is on the next slide. So based on our reading of published literature, which may be based on surveys and data like electronic medical records data, they generally show that the rate of telehealth use is lower among non-Hispanic Black residents and Black residents compared to non-Hispanic white residents. For example, from our sister agency, CHIA's 2021 Massachusetts Health Insurance Survey, they found that about 49% of non-Hispanic white residents reported having ever had a telehealth visit, which is higher than non-Hispanic Asian residents, non-Hispanic Black residents, Hispanic residents, and residents of other multiple races. And we know that within patients who are able to have telehealth visits, the specific mode of telehealth also matters. And we know that there are disparities in terms of video versus audio use by race and ethnicity. So here you can see on the right panel, here we used the US Census Pulse survey, which included a question on video versus audio use. They surveyed Massachusetts adult patients who reported having a video telehealth visit versus an audio visit. And you can see here that video use was highest among non-Hispanic white and non-Hispanic Asian patients, and lowest among Hispanic residents in Massachusetts. Next slide, please. The next area we looked at was the telehealth effect on total spending. And the challenge to answer this research question is that we know that spending and utilization decreased in 2020. So we really want to tease out the impact of telehealth from the impact of the pandemic, which led people to avoid care. So in order to do that, we constructed an analysis that asked, in areas with better access to telehealth services, did spending or utilization increase more or decrease less than in areas with worse access? If spending increased more in areas with better access to telehealth, then we could interpret that as telehealth increased utilization and spending. So to do this, we assigned patients into a high telehealth group and a low telehealth group based on their zip code. And on the next slide, to make sure that we are comparing patients who are clinically similar, we further categorized patients into 4 cohorts based on their health status: a cardiometabolic cohort, an asthma cohort, a mental health cohort, and a healthy cohort. So on the next slide, I'll show the results for the cardiometabolic cohort. So on the left, we have ambulatory utilization for the low telehealth group, and on the right, you can see results for the high telehealth group. So for both groups, you can see here that their ambulatory utilization decreased from 2019 to 2020 and decreased to a similar, pretty similar extent, about 15% for both groups. The high telehealth group did have more telehealth visits, 4.2 visits, but the higher telehealth use is offset by a greater reduction in their in-person visits. So this is suggestive that telehealth had a substitutive effect on utilization instead of an additive effect. Next, from utilization, we looked at spending, and you can see here the spending patterns mirror what we see in utilization. Spending decreased for both the low telehealth and the high telehealth group, and to a pretty similar extent. And after the cardiometabolic cohort, we wanted to highlight the mental health cohort on the next slide. And this we actually added based on commissioner feedback from our October meeting. So for this cohort, we wanted to divide their utilization into visits that are related to mental health conditions and visits that are unrelated to mental health conditions. So first, let's look at their non-mental health visits, and those are the bars in the lighter shade of gray. And you can see for both the low telehealth and the high telehealth group, their ambulatory utilization for non-mental health visits decreased. Then we can look at their utilization on mental health services, which is in the darker shade of gray. For the low telehealth group, their utilization is about the same from 2019 to 2020, 11 visits to 10.9 visits. However, for the high telehealth group, you can see all the way on the right, their total number of visits actually increased. So this suggests that telehealth enabled greater access to mental health care during the pandemic. I won't go through results for all the cohorts, but on the next slide, here's the spending slide on the mental health cohort. Again, because the higher telehealth group had more mental health visits, even though their total spending went down, the reduction in spending was slightly smaller compared to the low telehealth group. So on the next slide, I have a summary slide that just highlights the finding across these 4 cohorts. Overall, we found that average ambulatory utilization and total spending decreased for all 4 cohorts from 2019 and 2020. The extent to which utilization and spending changed was pretty similar for the low and high telehealth group for patients in the cardiometabolic, asthma, and healthy cohorts. For patients in the mental health cohort, we found that utilization for mental health services increased from 2019 to 2020 for the high telehealth group. This suggests that telehealth enabled greater access to mental health care during the pandemic and appears to have led to more visits than would have occurred without telehealth. Okay, then next we'll move on to the stakeholder section. Through the process to develop this report, we spoke to stakeholders, a range of stakeholders, including providers, payers, researchers, to really understand how telehealth has changed provider practice and patient experience, things that we're not able to get from looking at claims data. And these are some of the important themes that emerged from these stakeholder conversations. On patient experience, we heard that telehealth was a critical tool to maintain access during the COVID-19 pandemic, but in particular, telehealth was really beneficial for patients with chronic conditions that interact frequently with the healthcare system. And they're particularly important for patients that live in geographic areas where certain providers may be in short supply, such as specialists and behavioral health providers. We learned that it's important to know that they can greatly reduce patient time and travel costs. And we also learned that while video visits may be preferred by certain providers, audio-only visits are really important for certain patient populations. For example, older patients that have lower digital literacy, or patients that don't have reliable internet. And this is really important in terms of supporting health equity. Challenges, providers described that almost 3 years into this, they're still in the process of refining their telehealth offerings and figuring out how to develop this, how to develop care in this new hybrid model in an efficient way. They told us that telehealth billing and documentation requirements can be administrative complex and vary by payer. And we also learned that there can be disruptions to continuity of care when patients travel out of state due to licensure rules. On patient access barriers, we learned that low digital literacy and a lack of access to technology were the biggest barriers. And in addition, telehealth platforms, patient portals, and other materials are often not designed with an emphasis on equity. For example, we heard that certain telehealth platforms are not able to accommodate interpreter services. On the next slide, we also talked to stakeholders to learn their perspectives on payment. And we heard from providers that offer both in-person and telehealth services that offering telehealth services has not reduced their total practice expense. And this is because that they still require in-office expenses such as office space. Providers told us that oftentimes they're doing telehealth in their office because they have both telehealth and in-person visits on the same day, and they rely on the same administrative staff to handle tasks such as scheduling and troubleshooting during a telehealth visit. Provider organizations also said that they have incurred additional expenses for the technology to support telehealth. On the other hand, some providers told us that telehealth has improved their practice efficiency by reducing no-show rates and allowing them to schedule more appointments, sometimes at short notice. From the payer side, we did hear support for payment parity in some clinical areas, such as behavioral health, but some payers noted that they believe the marginal expense for telehealth should be lower. Like once the upfront, they noted that the upfront investment to set up telehealth might be high, but the marginal expense to maintain telehealth should be lower, such as lower head, and this should be reflected in lower reimbursement rates. And based on these findings, the next slide, I'll walk through the policy recommendations that we made in the report. So here are three recommendations that we wanted to highlight. These are what we think of as priorities for action for the legislature, and they're all about billing and payment for telehealth services. The first one is that we are recommending that the Commonwealth extend the sunset for the payment parity mandate on a limited basis, such as 2 years for primary care and chronic disease management. And the main reason is that we think this additional time would give providers some stability and allow them to continue improving their telehealth platforms and workflow, and to develop ways to best serve their patient in this hybrid model that can, in the future, take advantage of the lower resource needs for some telehealth visits relative to in-person visits. And the second recommendation is around facility fees. This is consistent with our longstanding recommendation to limit facility fees and certain common ambulatory services such as E&M services. We recommend that the Commonwealth should prohibit providers from charging facility fees for telehealth services to improve market fairness and consumer protections. In terms of, we did look at this in the data, and we found about 3% of telehealth visits had a facility claim attached to it in the APCD in 2020. So we know that this occurs only to a small share of telehealth visits, but this is a recommendation we sort of make on principle. And the third recommendation is around administrative complexity. Again, this is consistent with our previous recommendation on administrative complexity, we believe that coding rules and documentation requirements for telehealth services should be standardized across payers, including audio-only services, to reduce unnecessary administrative complexity in the healthcare system. On the next slide, we have two more recommendations in the area of billing and payment. One is that we believe that health plans and providers should continue to work collaboratively to adopt alternative payment models that would enable providers to incorporate a range of telehealth services into their practice, and depending on how they can best serve their patient needs. And the next recommendation is around payment parity for audio and video visits, because we know that audio visits are used by specific patient populations, such as those with low digital literacy and those without reliable internet connection. We think this is a really important recommendation to promote equity. We think that health plans should continue payment parity between audio and video visits to ensure that this is a viable mode of delivery for patients facing access to care. The next set of recommendations are the topic of access to care and health equity. And here we have 4 recommendations. The first one is ensure continuity of care when patients are out of state. The Commonwealth should consider policy changes and interstate solutions that would enable providers to deliver telehealth services to established patients who live in a nearby state or who are out of state temporarily. The next recommendation is around investment. We support policies and resources to foster patient digital literacy and to increase access to high-speed internet and connected devices. Here, our specific recommendation is dedicated funding to the Broadband Institute and to the HPC to pilot innovative applications of telehealth and to broaden the reach of telehealth to underserved patient populations. The next recommendation is on inclusive telehealth delivery, and specifically on the technology front. We encourage the development and adoption of telehealth platforms that incorporate accessibility features, such as the ability to integrate interpreter services. And the last recommendation in this area is also on inclusive telehealth delivery, but this is geared towards providers. We encourage providers to devote more resources aimed at increasing access to telehealth services in traditionally underserved patient populations, such as by translating patient portals and patient communication materials into multiple languages. And on the next slide is our last recommendation, and it's on the topic of consumer transparency. We know telehealth is new to many patients, and in addition to video visits, there are audio visits, and we know some providers are starting to charge for portal messages, and all of this can be pretty confusing to patients. When does it count as a telehealth visit? When is it covered? What is my cost sharing? So here our recommendation is that health plans should make these information readily available to their patients, and providers should clearly disclose any billing changes in their practice and notice patients in certain situations so that they are aware of their cost sharing obligations. And on my last slide, we wanted to highlight a couple of areas for future research and monitoring. The first one is on telehealth's impact on spending post-pandemic. This is an area that we're committed to keep monitoring as newer data become available, and we hope to investigate new areas that this research didn't particularly touch on, such as potential variation by race and ethnicity as data collection improves in the future. The second area we wanted to highlight is quality and outcomes. This is a really important aspect of telehealth, and we know that a lot of research is already coming out on this topic. Lastly, we wanted to highlight the third-party telehealth platforms and other emerging telehealth models. We know that in addition to telehealth services provided by traditional clinicians and provider system, that operate both brick and mortar facilities and telehealth services. There are a growing number of fully virtual third-party platforms that are growing in popularity with patients, plans, and employers. How are they being incorporated into plan designs, and how they affect spending and premium is, we think, an important area to continue monitoring in the future. So that wraps up my presentation. I will answer any questions that commissioners have and turn it back over to David Seltz.
Thank you so much, Yua. This is terrific work, very helpful. Let me kick off the discussion with 3 questions. First, are there any other states that have developed interstate solutions around the use of telehealth?
Yes, so there are different ways to go about facilitating interstate health. We know you can enter into a compact which go beyond interstate telehealth. They facilitate care for all medical practices. But if you just wanted to address interstate telehealth specifically, there are also different ways to go about it. As far as I know, I think 16 states have implemented long-term or permanent solutions. There are states that have created a registry system where the provider from another state registers so that they are able to do telehealth to patients in another state. You could create a special permit process that's not quite as burdensome as obtaining a full license. So states are going about this in different ways, and as far as I know, about 16 states have created a pathway to do this.
Great, thank you. Next question is, thinking back to the slides that you presented around the percentage of non-mental health visits that are provided through telehealth, is there a research-supported estimate of what percentage of visits are appropriately provided through telehealth, given the clinical condition? What I'm trying to understand is, let's say we see incidents of 50% telehealth visit. Is that most of the visits that would be clinically indicated, or do we have any way of putting that into context?
I think my understanding is that the provider community is still developing a consensus on what is the best use of telehealth for what clinical conditions, and we do know that I think non-mental health is a pretty big bucket. When we break these down by specific specialties, there's a lot of variations. We know that for primary care, for example, for preventive visits, I think data through the end of 2021 show us that very, very few visits are being done by telehealth. And it makes sense. For preventive visits, you really want to be able to see the patients in person. Compared to other visits, compared to other specialties such as neurology, I think is one area we've heard where use of telehealth is higher. So I think here the non-mental health services, it's a pretty big bucket. But when you break them down by specific specialty, you would see a fair bit of variation, and consensus is still being developed on what is the most optimal use.
Thank you, Yua. And last question for me, can you update the commissioners on what Medicare has decided to do around payment?
Yeah, so Medicare, as a reminder, before COVID, Medicare did cover and reimburse telehealth in some very limited scenarios. They paid for patients who lived in rural areas and only for a small set of conditions such as substance use disorders. At the beginning of COVID, Congress passed legislations, and the Health and Human Services enacted a number of regulatory changes that allowed all Medicare beneficiaries to receive telehealth services, including from their home. And Medicare reimbursed telehealth services at the same rate as in-person services. The latest development is that they is that President Biden has signed the Appropriations Act of 2023 at the end of 2022, which extended many of these telehealth flexibilities to the end of 2024. So I think our recommendation that payment parity be extended for 2 more years is consistent with the timeline of the recent legislative changes for Medicare.
Great. Thank you, Yua. Commissioner Cutler?
Thanks. So I also really thought this was great. I wanted to just make a couple of points and then suggest one thing overall. So one conclusion is, I thought when you went through the sort of complementarity or substitutability, I thought that by and large, what the evidence was suggesting was that telehealth was substituting for in-person visits. That, you know, in aggregate, we don't see a big reduction in spending for people who use telehealth visits. And we actually see what looks to be substitution, that is in-person visits going down, particularly for mental health, and telehealth visits, telemental health visits going up. So it looked to me like sort of in the first phase of telehealth, it really looks to be more substitutable. That's not terrible. It's neither good nor bad. I mean, we've long had a belief that we had too little primary care provided to people. So getting more, it would have been good had it been complementary in some things, so that, you know, some people could get more care. But it's not, it does, but, you know, substitutability is good, especially if people would prefer to do it at home or in the office or wherever. And that's what some of the mental health clearly seems to be. So I would sort of stress that more. I think the second comment is, in the short run, most technologies that can promise to save money often don't save money. Because the big money saver here would be in the space, like you just don't need as much space because you're going to do things from home, or the support personnel can work at home and so on. And in the short run, sort of organizations have committed to a fixed amount of space, like they have what they have. And so it's sort of not going to save on space costs that much and stuff. I think that some of that will probably take time. Like you could imagine that if a physician's practice or practice group is going to do half telemedicine, all of a sudden they don't need to have you sitting in the office to do telemedicine. They don't need to have the scheduler sitting in the office. And so over time, they can reduce the geographic footprint. And I think that's happening. Basically, we're sort of seeing that play out in healthcare, but it's playing out in business writ large, which is that, you know, most downtowns are still below where they were pre-pandemic. And as a result of that, demand for premium office space is somewhat lower than it was. And then folks will adjust, you know, because of that. They'll have some working from home and people sharing offices and not as big offices and stuff like that. And so I think that's to the good for healthcare. That is, if we can get rid of the need to build expensive new medical care facilities, or, you know, add on to them, or, you know, just maintain expensive facilities, and people can do that outside. Once we get that adjustment in place, that'll be very good. But it's clear that it didn't, like, you can't downsize that much in the short run. And that sort of leads me then to the observation, which is that in my mind, there's basically no way that we're going to have a really well-functioning healthcare system if it continues to rely solely on in-person visits. So it's just not a future for healthcare that doesn't take advantage of information technology. So I think as we think about policy here, there's no obvious savings in the short run, but there's no obvious expense in the short run. It seems to be better for patients. Over time, figuring out how to use it well clearly promises to be better off, unless you think like doctors are going to miss stuff, or doctors are going to, you know, screw up when they're on the phone or something like that, which there's no evidence, as you note in the second bullet here. So I think we ought to be thinking about how do we protect things so that telehealth, we don't kill it before we've had a chance to integrate it into what is a better healthcare system. So far, it looks not bad, and there's probably a lot more we can do.
Yeah, thanks for this comment. I agree, and I think this is you know, one of the reasons why we're making the consideration that payment parity be extended for a temporarily, which kind of gives providers some stability in a short term before payment parity goes away, allowing providers and payers to negotiate rates, but in the meantime, giving them some more time to figure out how to deliver care more efficiently.
It makes a lot of sense, and to innovate more in terms of supporting patients to have a very effective visit at home. You know, perhaps being able to take blood pressure measurements, other things on a visit, supported by the right equipment. Let's see, Commissioner Foley.
I think there was someone before me.
Was there? I definitely, we have two other commissioners who have comments.
Sorry,
I'll make sure to get to everybody.
Okay. This has been really great. Great report, and trying to soak it all in. I guess my question was really about the barrier of language capacity for the telehealth visits. I just kind of wanted to better understand. I know, is it an issue of the provider language ability or the need for translation during the telehealth visit? I know you mentioned the portal needs to be translated and the various materials to help support folks who are non-English speakers to access the services, but is it the clinicians and the need for a more diverse workforce with language capacity, or is it the need for interpreter services on the calls, combination of both? And I think that's a really important piece of the policy recommendations to address the barriers based upon language access and other language barriers. And just want to kind of better understand what the issues were that led to some access issues based upon language capacity.
Yeah, I think the as a starting point, what we heard was that it's the platform itself that isn't able to integrate a live interpreter. It only allows interaction between the patient and the provider, and they're not able to pull in a third person that could provide interpreter services. So some providers had to find a workaround, which is maybe you connect with a provider over the video, but then you also do a phone call at the same time so that they can have an interpreter at the same time. And providers are figuring this out. We talked to one provider organization who switched their platform recently to be able to add a live interpreter service and pull in some of the non-clinical functions. For example, you in an in-person world, usually after you finish your visit, you go check out, and the support staff is able to help you schedule a follow-up visit, which some telehealth platform isn't able to do. So the patient is left to figure out, how do I schedule a follow-up visit? And this provider told us that they switched to a new platform that allows a non-clinical staff person to be pulled in at the end of a visit. So they're able to schedule that visit right at the end. So some of the challenges are with the platform itself, but I think the other issues around language that you talked about definitely exist. Language on the portal itself and the patient communication materials, such as an appointment reminder. It's often sent only in English, and the diversity within the workforce itself. But I think within the platform itself, that's sort of a starting issue. It's not able to integrate interpreter services.
Thank you. That seems like an area all the providers just need to do better. I mean, the issue of trying to find the workforce takes time, and we got to do a better job. And that's, a longer term pipeline issue and all the other things we discussed with workforce. But the portal issue seems to be something that just needs to get fixed, and fixed immediately. It's a health equity issue and access issue for this population. So I would just really encourage folks that has to be addressed, and that can be fixed. The other issues are longer term. That are barriers we got to keep working on, but that seems like one that just needs to be addressed. Thank you.
Yeah, good point. Commissioner Castillo.
So thank you. I do like the recommendations. I think they're very important and they're very much needed. I think the ability to do it for mental health is incredibly important. We do have a lack of mental health clinicians, so that's an asset to be able to do that. I think it's an ease for the community, people who are working multiple jobs, even to take 10 minutes. I do see people through telehealth. I also see people through FaceTime and whatever access they have, whether it's WhatsApp and that's the only thing that they can do. I still see people through that, and they will take, you know, whatever, a 10-15 minute break that we can do some discussion. I do a lot of addiction care, and so it's an easier way for me to be able to treat people in that sense. I think one of the, certainly translations is an important piece that needs to be there. For me, it's easy because I speak the language, so certainly we need more people that speak the language. So that is not an issue for me, but it's an issue for the rest of the clinicians that are around and whatever other languages that are needed. So that's an important piece. I think thinking about universal Wi-Fi is an important aspect because we don't have, I mean, lots of people don't have the same access to the Wi-Fi. For my patients, they end up sharing phones. They do all kinds of stuff to get onto a telehealth service. So, and I also think for primary care, no, that will never replace a physical exam, but there are people who have questions that could be answered. And again, it's something that they can do during work. Again, addiction care is something that's easily done through telehealth, and primary care physicians do that. So there's a lot of other things that primary care can do that is helpful. And I can also see that as part of a clinical setting where you have some patients that come, you know, in-house to see you, and at the same time while you're there, you're also doing telehealth with somebody else who couldn't come in. So I don't see, I think it was David Cutler who said that I'm not sure the rates are going to go down. I'm not sure either. It'll be great if there was some, not rates, but the reimbursements would be great in the sense because now I forgot what I was saying, that it's just something that is good to have, because somebody will be at the office all the time and you're still using an office environment. And so,
yeah, to provide the visit in an office environment, you're not necessarily giving up that space.
Exactly.
Thank you.
Thank you.
Dr. Brewer?
Thanks, Madam Chair. Following up on Dr. Castillo's comment, if you go back to recommendation number 1, you know, I think it is prudent, as you mentioned. By the way, that presentation was awesome, just awesome. So fluent and so sophisticated. Thank you. I would hesitate to support extending payment parity indefinitely. Indeed, I might signal otherwise. I think right now we don't know what payment should look like. The sufficient studies haven't been done. There's a lot of economic analysis, public and health services research ahead. So yes, if the argument is just to allow further time to improve the services, for this to kind of get into the normalize it and get into the comfort zone, that's great. But I would personally like not to signal the commission's position on long-term extension of payment parity. We need a more sophisticated model for payment for telehealth. So I'd like sort of just to record that thought. Thank you, Tiff.
Yeah, very important. Completely agree. Great. Other comments or input or questions? As we think about taking our recommendations forward, realizing that the current mandates have expired as of January 1, what are the practical realities of what happens next when we think about the ability to potentially have the Commonwealth extend on a limited basis, as Commissioner Berwick said, the payment parity issues?
Yeah, so the mandate to reimburse at parity did expire on January 1st, but in reality, we know for now many payers are continuing to pay telehealth at parity. I think until some of the clarity on these issues come out, we know Mass Health, for example, is reimbursing at parity until September, as far as we know, the Division of Insurance has yet to release regulations on some of the telehealth legislation. For example, they're still working on the definitions of primary care and chronic disease management. So I think providers for now are maintaining their policies until there's more clarity on this issue. But I think, I mean, I'll defer to David's thoughts, but I think it's that we are hoping that, you know, in releasing this report, the legislature will take up our recommendation in extending the payment parity. David?
Well said, Yua. The legislature asked us for this report and for us to weigh in, and to do so on a timeline that was aligned with the original sunset of the payment parity for primary care and chronic disease. So we see this as being very responsive to that charge. Certainly legislation ensures that this is done kind of in an even playing field across, you know, commercial plans. But we hope that even these recommendations may influence the decisions of individual health plans to provide a little bit more runway, a little bit more of a glide path, as we've been talking about today.
Okay. Yua, any other final comments?
Nope. Just excited to for this report to be out in the world.
Yeah, absolutely.
Chair DeVoe, I'll just add one final thought, which is to say, while the issuance of this report, I think, is very timely and important, given some of the timelines that we've talked about, our work on this topic will continue. And as Yua mentioned, we are enthusiastic about having another year of data from the claims database to be able to analyze, to see if these trends persisted, did they change in future years. So we will be continuing to monitor this closely and talking to stakeholders in the future. So thank you.
Thank you. Any other questions or comments from commissioners before we turn to a vote? The vote today will be to authorize the issuance of the report. Any other questions or comments before we do that? Okay, Colleen, can I ask you to take us through the vote?
Perfect. Do we have a motion?
So moved.
And a second. Second. Okay, Chair DeVoe.
Yes, approved.
Vice Chair Cohen.
Approved.
Commissioner Berwick.
Approved.
Commissioner Blakeney.
Approved.
Commissioner Castiel.
Approved.
Commissioner Cutler.
Approved.
Commissioner Foley.
Approved.
Commissioner Haupt. Approved. Commissioner Master Giovanni.
Approved.
Acting Secretary Beckman.
Approved.
And Commissioner Lynch.
Approved.
Thank you.
Great. Thank you so much. Terrific work. We have two final agenda items to conclude today's meeting. One is the Executive Director's Employment Agreement. It's our timing to consider renewal of that agreement. And the other is a video presentation, about a 10-minute video presentation reflecting on the first 10 years of our existence. So I'm going to suggest that we conclude the formal business first, which is the Executive Director's Employment Agreement. For those of you that are following along on the agenda, we'll flip the last two items and then have the video shown as our final agenda item. So let me move to the discussion around the employment agreement, and David is excusing himself for this portion of the discussion. As you know, the existing term of our Executive Director's Agreement has, 3-year term has just ended. And so it's our timing to consider renewing that agreement. And I have gone through a process of performance review and met with the Administration and Finance Committee yesterday to present and discuss that performance review and report on that and have a discussion. And what we're looking to do today is to, I will summarize that and ask the board to authorize me to move forward and negotiate a successor 3-year term with David Sells. So the review process was that I conducted structured interviews with each of the commissioners and with select HPC staff during November, December, and January, and focused the interview questions on leadership and management, results and content expertise for the HPC, communications, and board stakeholder relations. I've shared a written summary of that performance review with all the commissioners that was distributed to you with your packets. But to summarize the results of the review, I want to report that David has performed extremely well in all of the domains that I explored. He's an exceptional leader, high-performing and effective organization, recruitment, retention, development of staff, a skilled and trusted communicator across all of the different constituencies, our board, external stakeholders, general public, and a respected policy partner to the other organizations and agencies that look to us and depend on us to move their agenda forward. So I got specific feedback from commissioners on areas of strength, opportunities for how we can work better going forward, and shared those with the ANF committee yesterday. In addition, I looked at compensation to make a recommendation to the ANF committee around the compensation for our executive director, had the opportunity to look at compensation terms for comparable positions in many Massachusetts state government positions. The most relevant that we really focused on when we met with the committee yesterday were the comparables for 3 organizations, the GIC, the Group Insurance Commission, the Connector, and SHIA, both because of their responsibilities and also because of their structure as agencies. And looking at those comparables, we had a robust discussion at the committee around base pay and annual increases going forward, consistent with what's the experience of other agencies. So based on that ANF committee discussion, we're prepared to recommend to the board that you vote to authorize me to negotiate a 3-year continuing employment agreement with our executive director in line with the range of comparable salaries and cost of living increases that was discussed in the committee yesterday, and the potential for proposing additional performance-based increases if they're warranted over the term. So let me open up for discussions or questions. We also, in considering the compensation for our executive director, taking into consideration the fact that it's very unusual to have a tenure of 10 years to have such an experienced executive director. So when we look at the comps, some of those incumbents are new to leadership of an agency. So we're taking that into consideration also.
Yes, Deb, that was the question I had, which is, are you happy with the comps? Because it's a rather special organization, and David's long tenure matters.
Yeah, really good point. And we had significant discussion about that in the committee. Very good point. Patty?
Yeah, are we just going into dollar specifics, or that's not something we go into at this level?
We don't have to. If there are any questions about that, I can certainly review all the dollar specifics.
Yeah, I think it's just important to say that our recommendation for salary was a substantial increase over where we are right now, reflecting the tenure and the performance and everything else like that.
Yeah, good point. Thank you. Thank you. And Commissioner Cutler?
I was going to speak not to the salary, but to the wisdom of reappointing David, which I'm very much in support of. I think in my own thinking, organizations sometimes need continuity and sometimes they need change, and probably they need a little bit of each all the time. I think at this moment, we've had a number of changes in commissioners, which I think is both sad because you lose some knowledge, but also good because it brings new perspectives. And I think at the moment, the healthcare system, it has a lot of challenges, ranging from all the things David was talking about with respect to employment and cost growth trends and so on. And so I think having someone, assuming that they've been doing a good job, having someone continue in the role so that we're not all trying to get used to something new, but actually going from the car that's already running, I think would be quite valuable. Again, assuming the person is doing a good job. My own personal assessment is that David is doing a terrific job. So I think that particularly for this position and this time, it makes a lot of sense to do so. And as an agency, we should always be thinking about how do we bring in new ideas and at the same time not upset things. But I'm right now quite convinced that this is the right path for us.
Yeah, very important points. I think both on your first point around the value of continuity, given where the amount of change that's happening within the commission, and also a new governor, new Secretary of Health and Human Services. It's just a moment for significant change, and the relationships and the credibility and trust that David has built, I think, serves us very well. And also that as I was coming on board with the commission and had the opportunity to outreach to a number of different external stakeholders, almost all of them brought up to me proactively how important it is to have the longstanding tenure that we have with David, given the amount of change that we know we need to make going forward and his openness to doing that. So I think both of those points are really important to highlight. Thank you. Other thoughts or questions or any other specifics that the board wanted to understand about either the performance review or the compensation? And to Commissioner Haupt's point, what I'm really asking for is the support to negotiate within the range of the comparables and the emphasis that the committee discussed yesterday on David's tenure and performance within that range.
Madam Chair, I would move that we authorize you to negotiate a new 3-year contract with David.
Second.
Okay.
You want to take us through the vote?
Absolutely. You first, Chair DeVoe.
Approved, yes.
And Vice Chair Cohen.
Approved.
Commissioner Berwick.
Approved.
Commissioner Castiel.
Approved.
Commissioner Blakeney.
Approved.
Commissioner Cutler.
Approved.
Commissioner Foley.
Aye.
Commissioner Haupt.
Approved.
Commissioner Master Giovanni.
Approved.
Acting Secretary Beckman.
Approved.
And Commissioner Lynch.
Yeah.
Thank you.
Thank you. Thank you all. And while we invite David to come back to the meeting before we show the video, I just wanted to mention our schedule of upcoming meetings. So as David had referenced earlier, our committee meetings will happen on February 15th, both the Market Oversight and Transparency Committee and Care Delivery Transformation. Market Oversight begins at 9:30 and Care Delivery at 11. All commissioners are invited to attend, whether or not you are officially on those committees. And then our full board will next meet for the benchmark hearing, the annual benchmark hearing, which is scheduled for March 15th. And then the next regular board meeting is scheduled for April 12th. So the March 15th benchmark hearing is our board meeting for that month. Any other meeting updates, Colleen?
No, I think you covered it.
Okay, great. And did you let David know that he can rejoin when he's
He's on his way, but I think we can move to the next item.
fine?
Thank you.
Great. Well, why don't we turn to our last agenda item, which is a video presentation that will also be up on our website that documents our 10-year anniversary.
Yes, absolutely. I'm very excited. Thank you, Chair DeVoe, to introduce 2 new releases from the HPC to celebrate and commemorate the 10th anniversary of the agency and, more importantly, our founding legislation, Chapter 224 of the Acts of 2012. As we have said before, this anniversary presents an important opportunity to reflect on the past, while at the same time charting a bold path forward for the future. So first on this slide, as shown on the left, we've developed and published a new interactive digital timeline showcasing nearly 50 of our most significant achievements and events since the establishment of the HPC. There's links to relevant research, reports, other materials. I really encourage everyone to check this out. I think this is going to be a really important resource and compendium for our stakeholders and everyone moving forward. So we're really pleased to have gathered this information all in one place. And then to further chronicle the milestones of the last decade, we are thrilled to premiere a video with you all today featuring interviews and reflections on the Commonwealth's successes in healthcare reform so far, as well as the vision for the future. Before I play the video, both the digital timeline and the video are already available on our website. Those are posted. And I just want to say, you'll see their faces, but thank you to everyone who assisted and contributed to these releases. Dr. Stewart Altman, Chair DeVoe, Vice Chair Cohen, Commissioner Cutler, thank you so much for sharing your really unique perspectives and experience. And from our HPC team, I just want to shout out Ellie Mador and Aisha Anderson, who made all of this happen. I'm just presenting it to you today. So thank you for them. This was a massive project over the past year. So, all right, Ellie, I'm done with the intro. Do you want to play the video for us?
In 2022, Massachusetts marked a milestone anniversary in its ambitious journey of healthcare reform. In 2012, with a broad consensus to restrain rapidly increasing healthcare costs, the Commonwealth enacted landmark healthcare cost containment legislation. The law established the Massachusetts Health Policy Commission to monitor and guide this ambitious effort. Now in its 10th year, the Health Policy Commission's mission is to advance a more transparent, accountable, and equitable healthcare system through its independent policy leadership and innovative investment programs. The HPC's goal is better health and better care at a lower cost for all residents across the Commonwealth.
This is a significant milestone, 10 years of the Health Policy Commission. The history of Massachusetts healthcare reform is important for this story because Massachusetts in 2006 became the first state to really focus on healthcare access. This was landmark legislation that was an experiment in the truest sense of the word, and it was a success. Massachusetts became the state with the lowest rate of uninsurance of any state in the country. After the passage of Chapter 58 and healthcare reform, the challenge really became, how do we sustain that promise in the long term? What we saw at the time was that there was double-digit growth in the cost of premiums and the cost of healthcare, and that was just unsustainable. We had to find common ground once more and advance legislation that would again put Massachusetts at the forefront of all states. And that became Chapter 224.
It was the hope of the legislation that overall healthcare spending would not grow by more than the growth in the state income. In doing that, it then set up 2 commissions to oversee the system. The Center for Health Information and Analysis, CHIA, to collect the data and the Health Policy Commission to monitor, to advise, and to, most importantly, to inform the public.
One of the foundational elements of Chapter 224 was the establishment of a healthcare cost growth benchmark. This is a target for moderating the growth in annual healthcare spending year over year to something that is more sustainable and affordable in the long term. The legislation also established the Health Policy Commission as the key state agency to monitor the state's performance against the healthcare cost growth benchmark.
This benchmark, as it became known as, dealt with the growth. So it didn't say that healthcare spending had a decline. It said it's important that spending grow, but that it grow in line with the state's ability to pay for it. Soon after we began, our largest delivery system at that time, called Partners Healthcare, recommended that they wanted to merge with and essentially buy two of our largest community hospitals. When there is any form of mergers or acquisitions that could affect how the system operates and potentially lead to increases in healthcare spending or reductions in access, the Commission is responsible for writing a report to outline in detail what the implications of that merger and acquisition are. It ultimately led to the judge supporting our recommendations, and that merger did not go forward in the way it was set up. In previous years, the likelihood that that merger would have gone forward would have been very high.
The Health Policy Commission recognized that in order to influence the healthcare market, we needed to use a variety of different levers in order to affect change. We are a watchdog on behalf of the residents and the businesses of this state who are paying the high cost of healthcare. In that role, we are acting and calling out behavior and activities that are counter to the goals of our healthcare cost containment legislation.
The data has enormous impact. We know more about the medical system in Massachusetts than any state knows about its medical care system. We have a superb, absolutely superb data infrastructure, from CHIA, the Center for Health Information and Analysis, to our own internal cost trends team. We know as much as we can know about the medical system, from what's happening to costs, to what's happening to measures of utilization, to what's happening to margins, revenue margins, profit margins at different organizations, to what's happening to social determinants of health. Here are the things that are going on in the Commonwealth. Here are the things that are going well. Here are the areas in which actually we're not doing very well. Here are areas in which we're not doing very well, and actually we're not getting much better. We will talk to anyone at any time about all the data that we put out, get suggestions for how we can improve what we monitor, how we monitor it, how we report it, anything like that, so that it's the most helpful in all the Commonwealth's discussions.
In 2015, the Health Policy Commission launched our first major investment program, where we were going to partner with community hospitals to drive innovations in healthcare delivery. We called that program CHART. CHART really became the foundation for a series of additional investment programs that we would launch in the years to come. Many of these were focused on really pressing needs in our state. These targeted investments have become a foundational cornerstone piece of the Health Policy Commission's work to drive innovation and efficiency in healthcare.
To me, the real work of the Commission is its investment in providers to actually transform care. And it's done that really since inception. As a result, I think we've got a higher level of care that is focusing on performance, that's focusing on health equity, and that's really focused on integration of care in a much different way than we would have seen otherwise.
Massachusetts is rightly proud to be a national leader on healthcare reform. We have seen that healthcare cost growth has moderated in Massachusetts. In every year since the establishment of the benchmark, healthcare spending growth was below a comparable U.S. average. And that is a complete change from prior to the establishment of the healthcare cost growth benchmark. The fact that now 7 other states are pursuing their own cost containment strategies inspired by Massachusetts provides an incredible opportunity to help inform our improvement efforts. How are we going to evolve our strategy for the future?
I like to believe that we're providing even more and better care than we did before, but we're doing it in a more organized way.
Coming out of this COVID-19 pandemic, we are facing extreme headwinds in the form of inflation and labor costs. And at the same time, our residents are still struggling with the cost of healthcare.
3 out of 4 people in Massachusetts are concerned about how they're going to afford health care now and in the future. And half of adults that were surveyed in 2021 have not received necessary care because of the cost. We've proposed a set of recommendations for 2023 and are looking forward to working with the new governor and legislators to consider and hopefully move forward on some of those recommendations.
We're very proud of the success of the Health Policy Commission and Chapter 224. This foundation will serve us well for the next 10 years because the challenges are even bigger. We need the renewed commitment of all of the stakeholders, of policymakers, and the new administration to double down on our efforts because the residents of the Commonwealth need affordable health care.
Very, very nice. Wow.
Really well done. So, as Colleen said, it's a tremendous amount of work to pull together, as you know, a presentation of that complexity and depth, and I think it's a terrific job. We will use that in many different ways.
Yeah.
Thank you. Thank you all so much.
And it was very kind and very appropriate to specifically acknowledge Stuart and Mary Lou the way you did. That was wonderfully done.
David, if I recall, my biggest contribution to the commission is suggesting we have colors, as you noted earlier, green, yellow, and red. So first off, that is entirely a green light presentation. But I also think that, like, looking at that, I'm just come away by saying, for all the yellows and reds that we've given ourselves over the years, we should also give ourselves a very big green for having done a lot of good work for the Commonwealth. And I don't think of that as testament to me so much as I think of it as testament to you and the staff at HPC, and of course, Stuart and the secretary and all the other folks. But it's really striking to see it and to remember it all.
Well, thank you, commissioners, and thank you, Colleen, and to the team for putting together that great video. And definitely is a trip down memory lane for some of us who've been here from the beginning, as you have been, Professor Cutler. So I will accept that green light. I am grateful for the opportunity to continue this important work with all of you, with the new Healy-Driscoll administration, and of course, with the incredible team here at the HPC. So thank you for a great meeting today. And I'll turn it over to Chair DeVoe to close us out.
Thank you, everyone. Any last thoughts before we sign off? Okay, terrific. Thank you for a very good meeting. And we'll see you next at the benchmark hearing.